So we continue with placental baby. Okay, let me ask you a question here. I think we said with BIC there's going to be bleeding and clotting at the same time. I want to ask you if there's a pregnant woman who comes to your unit and complains to you that for some days now he has not been feeling any fetal mobility. Okay. In terms of labs, what do you think we are going to order? Yes.
Can I answer?
Yes, please.
You that she's not feeling any movement.
Sure.
First, I want to check for fetal. I would like to. Wait, are you asking for blood test or any?
Labs. Yeah, labs.
Okay, I'll check for human gonadotrophin.
Human gonadotropin hormone.
Yes, yes.
Why so, please?
Pardon?
Why so?
Why so?
Yes.
Because if the baby is dead, or you want to check if there's still life.
Oh,
Maybe, yeah, we want to check if there's still life in her.
all right. Thank you so much. Any other labs that you request?
Sir Frank,
Yes, please.
can we do abdominal pelvic USG?
Abdominal pelvic USG. For sure. That's what we are going to do. Okay. So, all right. Thank you. Any other? So, if the mother has not heard any fetal movement for some days now, okay, someone says the WBC US, okay, for some days, what do you think the mother is at risk of?
Sir, please, can we do biophysical profile?
Biophysical profile. That one, yes, we are going to do. That is assessing the well-being of the fetus. Okay. That is all that you said. They are all important. But if you are answering these type of questions, okay, bear in mind, they are looking at once you are not hearing fetal movement. Okay. And we are supposing that we are having intrauterine death. Okay. We always think of the complications that may result. The complications. Okay. There are something that assessing the fetal well-being, that's fine. You can do that. You're doing USG, you are still confirming. Okay. But when we are answering such questions, please, let's think of the complications. I think today I posted the questions, like I think that was infection. It's all about infectious conditions. Okay, and it asks you the one that you have to follow up. Sometimes, the condition comes with expected signs. So once you are having a condition, we are looking at things that is not expected. That is the complication that it may develop. So once you are having a patient who doesn't feel any fetal movement for some days, number one thing that you can think of is probably there's IUD, okay, intrauterine death. And once there's intrauterine death, the most serious complication that we are thinking of is what? DIC. Are you following? DIC. Okay. And if there is DIC, we have to assess. What are you going to assess for DIC? How are you going to know? But this is DIC. There's DIC. How are you
Clotting
going to?
factor.
Yes, your clotting profile, your coagulation studies. Okay, that is going to tell you you are going to have that prolonged clotting. Your platelet level. I told you that those that are used for clotting, like the platelets, like the fibrinogen, and then the clotting factors, they are used for clotting. Okay, and that one will be what? Very high, as well as D diamond that shows that there's clotting ongoing. And those that's because of bleeding ongoing, it could be what? Prolonged clotting factor, APTT, PT. They will be very high. So please, in such scenarios, think of the complications that may result. And once there is complication, what is the commonest complication that we are thinking of? DIC, because intrauterine death, the most common one is DIC. The most common complication, DIC. Okay, that's why sometimes when the mother says, I'm not feeling the fetal movement, quickly you have to do your assessment, like the ones that we talk of. But the most serious thing that we are afraid is the complications that may result. That's clear. And I told you that.
So please, can I ask a question?
Yes, please.
Okay, yes, I understand that we are looking for the complication. But would the complication give a final diagnosis like, okay, because this is the complication that we have identified, it means that the baby is dead. It means the fetus is no longer living. Because I understood the question like you want to confirm that the fetus is actually not moving because it's lifeless.
Yes. Yes, I told you that. That's obviously you're going to do assessment. Okay, I told you that obviously you're going to do your assessment. And one of your assessment findings that we talked about is when that's there's going to be you are going to do
I see.
ultrasound. Okay, you are going to do fetal surveillance like what's the name? Like biophysical profile or NST. Do you understand? We are going to do all those things just to confirm that if the thing there is viable. Do you understand? But over here, my concern is that there is what's the name? The mother has been complaining that she has not been hearing fetal movement for the past days. Okay, no fetal movement has been noticed. Okay, once it happens like that, what do you think of the most common complication? That is DIC. Okay, so if there's complication, it's like if you read a question that I've been posting, if the question asks you of sometimes we have expected and unexpected. Okay. The question was asking you things that you are going to be your priority. And always the unexpected findings take priority. The unexpected findings. So what I'm saying is once there is fetal death, mind you, our serious complication that we fear most is DIC. Okay. And how are you going to assess that? Okay. How are you going to assess that? And it depends on the person. So the first thing is you're going to assess. Obviously, you're going to assess. That's the first thing that you're going to do. The mother comes to you, he says, this. You're going to do your assessment findings. And as part of your assessment findings, we are looking at once the mother has not been experiencing any fetal movement, obviously we are suspecting what? Intrauterine death. That's what we are suspecting. And once there's intrauterine death, we are also afraid of the complication that may result. Okay, and that is what's the name? That is DIC. Okay, and the things for you to know that there's ongoing DIC is to do your clotting profile. If you understood me.
Yes, sir. Thank you.
That's what I just want to know. But obviously you can't ignore your assessment. Okay, you can't ignore your assessment. All right. Okay. So, I was telling you about VIC. So let's move forward. So that is VIC for you. And let me ask you, what's the normal APTT time? What's the normal APTT? Yes. Hello?
60 to 100. Oh,
Okay. Right. Any other? Okay.
35, that's 5.
So that is the baseline, but you have to multiply it by the baseline. So ideally when the patient is on heparin, okay, that one obviously you are going to look at the therapeutic range, okay, yes, and that is 46 to 70 seconds. You understand? Okay. All right. So let's move forward. I want to ask a question. So our next topic is placental abruption, placental previa. Okay. All right. So with placenta previa, as we've already talked about abruption, that one's sub. But with previa, just it means that we are looking at the placenta. Okay, and that is one of the emergency conditions in pregnancy. So the placenta is implanted in the lower uterine segment. Okay, and it could be either partially or completely covering the lower uterine segment. Okay, it can cover it completely or partially or minimal. Okay, so know that we have types. It can be complete, meaning that it is covering the lower segment entirely. All right. So that one, look at where the placenta is situated. The lower uterine segment. Okay, the entrance to the uterus, the cervix. And if there's dilation, it means that that placenta is going to detach itself from the wall of the uterus or from the lower uterine segment. And that one is going to result in bleeding. Okay. And we may have partial, meaning that it's about 3 centimeters away. Okay, from the os, the cervical os. Okay. And we have marginal. Marginal is a bit away. Okay. But still, it's a previa. It's implanted in the lower uterus. But that's not the ideal situation. Okay. And with this one, if we are having complete placental previa, that one calls for emergency CS. Because we are always afraid of the child oxygenation. Okay, if the child is not getting enough oxygen, that will lead to fetal distress. So with complete previa, we have to go in forward. CS. So looking at the types, marginal. Okay, look at the placenta. You see that the umbilicus, okay, connected to the placenta. This one is the margin, okay, of the wall of the placenta. And look at the B, which is the partial. It's like there's a partial occlusion. Okay. And all the marking has to do with 3 centimeters. Okay. So if it's from this orifice to the edge of the placenta, if it's within 3 cm, that is what? Partial. If more than 3 cm, that is marginal. But with total or complete placenta previa, it covers it entirely. Okay, it's covering the internal os completely. That is the complete one. That one, if the cervix is opening, the placenta is going to get detached from the walls, and the patient will the fetus will be depleted of what? Blood and oxygen. Okay, so which will going to put the child at risk of fetal distress. All right. So what are we going to assess? Okay, what are we going to assess? We are saying that the hallmark symptom is pain. I hope you remember when we were dealing with placental abruption. That one is abrupt, so it comes with pain. And that one, the placenta is just at the normal situation. That's the upper part of the fundus, okay, of the placenta. And with this one it's lying at the lower marginal, lower end of the cervix. Okay, so this one is abnormal situation. With previa, it has an abnormal situation, unlike the abruptio where that one has the normal situation. But with previa, because it's so close to the orifice, the cervical os, okay, if the placenta should get detached from the wall, patient is going to bleed. And because it's so close to the cervix, to the opening, you're going to see bright or red blood. But supposing look at the buttocks of the fetus. Supposing that the placenta is at the buttocks of the fetus, before the blood gets to the entrance, I told you that by then the oxidation and then absorption of the what's the name? The oxygen has already taken place. And that one is going to lead the blood to be what? To be what? What color are we expecting? In abruptio.
Dark.
In abruptio,
red.
dark.
But the one which is close to the orifice, the what? Bright.
Bright.
Okay. And that one, because it's not abrupt, that will be what? Painless. Okay. It's going to be what? Painless because it is not abrupt detachment. I hope that's fine. Okay. And we are also seeing it occurs suddenly. It occurs suddenly. Okay, and it's recurrent. All right. So once there's detachment and patient is bleeding, obviously the uterus is going to be soft. Right? It's going to affect the fetal heart rate. This is going to affect the fetal heart rate. Mind you, it's going to affect the fetal heart rate. Okay, good. So that's what you are supposed to know. And another thing is that so the fetus, is it going to develop bradycardia or tachycardia?
Bradycardia.
Bradycardia. Bradycardia happens when you are looking at the later stage. But at the beginning of the situation or the casket, we are going to experience tachycardia because the fetus will be in distress. All right. The fetus is going to be in distress. And if the fetus is in distress, all right. But mind you, is there a difference between late decel and bradycardia? Late decel and bradycardia. Is there a difference?
No, sir.
All right. Someone is saying no. Okay. Any other person? Bradycardia and late decel. Is there a difference? Yes. Please, let's talk. Who is that?
So late decel happens in relation to contraction, but bradycardia is just a low heart rate.
Okay. So late decel happens with compression when, and that is when the placenta is insufficient, not able to supply enough blood to the fetus, and that one happens after contraction has ended. All right. And bradycardia, that is a decrease in the heart rate. A decrease in the heart rate. Doesn't matter if there's contraction. Okay. So at the beginning of the issue or the problem, there's going to be what? Fetal distress. That will put the patient at risk, the fetus at risk of what? Getting fetal tachycardia. Okay. And uterine tenderness. Uterine tenderness. Okay. We are saying that there's not going to be any uterine tenderness because obviously placental previa, placental previa is what? Pain-free. Okay. And fetal heart, fundal height may be more than expected than the gestational age. All right. That's also going to happen. And once it happens like that, please, our focus here is much on the fetus before we even come to the mother. Because the fetus is going to experience the initial symptoms. Okay. Before the mother even comes in to develop hypotension as late sign. Okay. So we have to monitor the fetal heart rate. What is the fetal activity? Is it in distress or not? Okay. And we have to also prepare for ultrasound to confirm the diagnosis. But mind you, please take note of this. Vaginal exam or any other actions should be avoided. We don't do vaginal examination when patient is having placental previa. Because your hand is not, once you do examination, you put the patient at risk of infection. And apart from that, you're also complicating the bleeding. If there's clotting ongoing, or if the place is forming a clot, to just prevent the bleeding, they're going to cause a disorder of this, and that one will complicate the maternal condition. All right. So please note that we never do vaginal examination. Mind you, we never do vaginal examination. Are you please okay? But mind you, notwithstanding, we can also do what we call speculum exam. Okay. When in that one, if let's say there is mostly we do it when there's a rupture, okay, of membrane, especially if there's a premature rupture of membrane. Okay, premature rupture of the membrane. You have to do what we call the speculum exam. But mind you, we don't do heavy lifting because we want all these things will lead to bleeding. So vaginal exam is avoided, heavy lifting, sexual intercourse is avoided, strenuous activity is avoided. So please be reading through your your options. If it has to do with strenuous activity, please don't do. Over here is not about getting the woman to do exercise. No. Okay. The mother needs to ensure bed rest for some time. Okay. Before we can go on if there's the need for exercise later. But initially, please, we need to ensure bed rest. Okay. And that was because all these things is going to stimulate the uterine activity, and that will complicate the maternal condition. Because of bleeding, it says, do not administer oxytocin. Okay. Do not administer oxytocin. Are you here?
Yeah.
Yes. We do not administer oxytocin here. All right. We have to maintain bed rest. That is in a sideline position. Okay, because, and that would mostly left lateral. Okay, just to prevent or maternal supine hypertension. Okay, and we need to also monitor the amount of blood that is coming out, but that will tell us if the mother is developing signs of shock or not. Okay, we also need to administer IV fluids because the blood that is coming, we need to replace it with fluids as well as with blood. Okay, or tocolysis as prescribed. Okay, RH because the bleeding program. Okay, because of bleeding, there's possibility of measure, and we do also administer betamethasone as prescribed. Okay, we do all these things if there is what. Why do you need to give betamethasone here?
Lungs maturation.
Yes, if the fetus is pregnant and you want to mature the lungs, you need to mature the lungs. As long as the fetus is there and delivery has not started, we have to do that. Okay. So over here, because we are saying we do not administer oxytocin. Why? Because if there's oxytocin, it's going to cause what? Contraction. And contraction will lead to dilation of the cervix.
And we don't want that.
Yes, and you don't want that. Okay, because it's going to be the fetus is going to descend. That will dilate the cervix. So we don't want to do anything that will dilate the cervix. So we rather give what? Tocolysis. An example is what? Nifedipine. Okay, nifedipine. So we have to and give road program. Okay. And if the bleeding is heavy, then we prefer what? CS. All right. So that's what you should know. Okay. So how do we interpret? If bleeding stops, okay, then we can manage the client at home. Okay. But we want to, with this, we want to let the mother know that once she experiences let's say vaginal bleeding, continuous vaginal bleeding, okay, but we only manage at home if delivery is not due and vaginal bleeding has stopped. But if there's ongoing vaginal bleeding, we can manage at home, okay. Or if there's signs of a contraction, you have or signs of this rupture of membrane. Once the membrane is ruptured, we can't let the mother go home, okay, because that one the baby needs to come because if we delay delivery, the baby will be at risk of getting an infection. All right. And there's also if there's decreased fetal movement. Okay, if there's decreased fetal movement, because initially the fetus will be in that distress, and later if the patient the fetus is in distress, it's a problem. Okay, so we have to, if the mother meets all these conditions, we have to manage at the hospital. But if not, if bleeding has stopped, the mother is stable, we can continue managing at home. All right. So we only prepare for emergency CS if the mother is pregnant, less than 38 weeks. Okay. So in that case, once there's ongoing bleeding, okay, we can also prepare the mother for emergency CS. Pregnant. Okay. Once we mature the lungs, then quickly we do delivery. Okay. So if the client is less than 34 weeks with trivia, we administer steroids. The last time we established that steroids is given to just boost lungs maturity. Okay. And also, we need to also monitor the blood. Okay. Be counting the pad. Know your H and H, your hematocrit and what? Hemoglobin. Know them. That will indicate to you that the mother is bleeding.
Hematocrit 135.
Are you please okay?
Yes, sir.
Okay. So that is what we should. All right. So let me ask you. Okay, I'll ask later. Let me preserve this question. I'll ask this question. Okay. So just know what you are supposed to be. Okay, know what you are supposed to be. So if the mother is having this, the methazone can be given. Okay. So that's that. All right. So we are saying that vaginal delivery would tear placenta villi and it's contraindicated in previa. In previa, that's why we don't initiate contraction. We don't want to get contraction. So mother prevents being given what? Oxytocin. Okay. So that's what we have to know. In previa, no contraction. Contraction is contraindicated. Okay. We only deliver by CS. So that also will depend on the degree of the position. Okay, or the type of the previa that we have. Okay, that's what you should know. So if there's persistent bleeding, signs of labor, I hope you know signs of labor. Okay, signs of labor. And with signs of labor, we're going to have continuous of consistency in contraction. Okay. And we are also going to have maternal distress. This one we have to deliver because there has been bleeding. So the mother will run into shock. That one will warrant what? Emergency CS. Okay. And if there's fetal distress, that's non-assuring. Okay, fetal distress, non-assuring. We need to do emergency delivery. Any question, please, before we move on? Any question?
Yes, Boss Frank.
Okay.
I just want to ask, with the betamethasone given for the lung maturity, is it given only in previa or in all preterms? Because I've seen babies delivered in 30 weeks and it was not given. So it just kind of, I want some clarity there. Yeah. Thank you.
Okay. So with betamethasone, we give based on the emergency of the condition. Okay. If like the mother presents the unit and delivery, we know delivery should be done immediately based on the condition. Can give DESA as part of your management. How you get it? Because the last time, I think, was it in this class or discussion? We said DESA about 24, 48 hours. Okay, then it starts working and it starts with the help of what? Maturing the fetal lung. Okay, so it depends on the urgency of the condition. If the condition demands urgent delivery, there wouldn't be any need for DESA. But if we think we can delay delivery, for example, the mother has come experiencing rupture of membrane, okay, or experiencing any other condition, but the service is still intact. Okay, we don't know when the delivery will come. All right. So in that situations, we may give what DEXA. But if the condition demands urgent intervention, we wouldn't delay by giving DEXA. I appreciate it.
Yes, thank you.
Okay. So that is it. Any question? Okay. All right. If there's no question, then we are going to move on. So we are going to talk about hyperbilirubinemia. When we say hyperbilirubinemia, we just know it's high, bilirubin in the blood, emia, blood. Okay, so elevated bilirubin level in the blood. Right, and that one is different from jaundice. Jaundice is just the discoloration of the skin, as well as the sclera in the mucous membrane. Okay, the mucous membrane. You are looking at the mouth. Sometimes you can see it on the mouth. You can see it on the eyes. We are looking at the mucous membrane. Okay, and that one happens as a result of what? More bilirubin. Okay, and jaundice. When you see jaundice, it tells you that it's a sign of underlying condition. Okay, the sign, not the condition. The sign that there's something ongoing. Okay, and you know, hyperbilirubinemia is just we only notice after doing what? Lab works. All right. So bilirubin, the source of bilirubin is from RBC breakdown. If there's RBCs, the red blood cells is breaking down, okay, there's going to be divisions because RBC has to do with what? Hem part, we have the hem part and all, the iron part. Okay. So when there's a breakdown of bilirubin, okay, there's going to be hem release. Okay. And the hem that is released is unconjugated, meaning that if a hem is released, it has to go to the liver for the liver to work on. So if the liver has not worked on, it is seen as what? Unconjugated. Are you please okay? So this unconjugated bilirubin, which is the hem, okay, will be transported or be carried to the liver, and the liver will conjugate it. Okay. And once it's conjugated, it can safely be removed from the body. All right, either through urine or through stools. So that is what you should know. Once there's RBC breakdown, that is unconjugated, and unconjugated cannot be removed unless it becomes conjugated. It becomes, the liver has to work on it. And unconjugated bilirubin is highly toxic to the body. It's highly toxic to the brain. So that's what, so once you see the yellow discoloration of the eyes and others, the sclera and the other mucous membrane, it has to, you have to know that it's just unconjugated bilirubin. Okay, unconjugated bilirubin. Because once it's conjugated, it is removed from the body via what? Bowel or via stools or urine. Okay. So in newborn, it occurs if there's a decreased elimination. Okay, the bilirubin has been created, but the decrease, you're having a problem there. Okay, or if there's an increase in the breakdown, we are having excessive breakdown, which will lead to more bilirubin in the blood. I mean, RBC's breakdown. Or if the bilirubin has been broken down, but it's not being released from the, it's not being eliminated. That's the way. It's not being eliminated from the body. It's going to develop. So with these two ways, we have bilirubin in the blood. And when we have decreased elimination, okay, if you are not feeding, because I told you that it's either excreted via what? Where? Where is it excreted from?
Urine or
Yes, stools or urine. So it means that if the baby has been born and you are not feeding, elimination will be decreased. So poor feeding leads to decreased elimination of bilirubin. Okay, because once the baby is born, there are a lot of immature red blood cells. And these immature red blood cells have to be what? Broken down. Okay, has to be broken down. So that's why we encourage early breastfeeding once the baby is born, because especially with the what's the name, preterm, they have a lot of what's the name? What's the name? What did I say? A lot of what?
Immature.
Yes, RBCs. Thank you.
Immature red blood cell.
Yes, they have immature red blood cells. Okay, they have immature red blood cells. So if the baby is born, and once they are immature, they are going to be broken down in the blood. Okay, and they have to be what? Removed from the system. So that's why we encourage early breastfeeding. So feeding, if the child is dehydrated, where is it going to be removed? By the urine. How? Because it's dehydrated. The output is reduced. Okay. The child is not passing meconium, because once meconium is passed, that's through it, bilirubin can be removed. Okay. So all these things, if we delay in meconium passage in feeding, is going to slow down bilirubin excretion. And if there is immature liver enzymes, because these liver enzymes break down the what? The hem. Okay, they break down the unconjugated, because once it is destroyed, it has to go to what? The liver for conjugation. And the liver, if it is immature, and where do we get this immaturity from? Preterm. Okay, preterm babies, if they are preterm, their liver is immature. Okay, and that one, the enzymes cannot break down, or they cannot conjugate the hem, the bilirubin. Okay, and that is when we have decreased elimination. The one that is working on, and after it has been worked on, how to remove, a way to remove, either through stools, which is being delayed, or through urine, which is when you are having poor breastfeeding. Okay, and we are having increased RBC breakdown from trauma. If there's cephalohematoma, we know cephalohematoma, we have blood clots, okay, hematoma, all right, which has been formed on the head, okay, cephalo head. So once this is, so we know cephalohematoma, how does it go away? How does it go away? Yes, it's through this. Okay, it needs to be broken down. The RBCs. Okay, and once it is broken down, it has to be what? Conjugated in the liver. Okay, so if there's you give birth to a child with cephalohematoma, know that the hematoma is red blood cells part, and this red blood cell is going to be broken down, and once it does that, it has to be carried to the liver for conjugation. Okay, that will increase the RBCs breakdown. Okay, and maternal fetal blood type incompatibility. As we all know, if the mother is negative rhesus factor, or even the mother is O, and the fetus is other group, okay, it will lead to RBC breakdown. So if your blood group is incompatible with the mother, and during that time, if there's blood mixing, we are going to have an increased RBC breakdown and increase the bilirubin level in the blood. Right, please, okay. So we know that with this, we have types. Okay, and we have That's one caused by what? A temporary what? Elevation of serum bilirubin due to immature liver metabolism. The liver is not mature enough to metabolize or to conjugate the bilirubin. Okay, and hence we are having not more of it, that is bilirubin in the blood, that's serum. Okay, an increase in the red blood cells breakdown, and that appears after the first 24 hours. And that is what type of breakdown is that? Yes. Is it
Please come
physiological
again
or
with the
pathological?
question.
Physiological.
Please come again with the question.
That is what
It's a
my question is.
breakdown.
We have sometimes when we give birth, okay, obviously because of some sort of immature red blood cells in the baby's blood, there's going to be what? Breakdown. Okay, so if we have the breakdown and the fetus is developing signs of the hyperbilirubinemia, that is, you're having signs of we have jaundice, we have skin color change and those stuff. Okay, once you have all these things, some can occur, breakdown, or this jaundice or these signs and symptoms can occur within the first 24 hours of life. Okay, and we can also have those that occurs after 24 hours of life. Okay, so when the child is born and the child is having signs of jaundice, signs of hyperbilirubinemia within the first 24 hours of life, what type of jaundice is that? Is it
Pathological.
It means that the baby brought it from birth. That is pathological. Within the first 24 hours, we are having jaundice. It means that the baby came with it. And that is pathological. That's a disease condition the patient is having. But after 24 hours of life, we start seeing this. Okay, that is physiological. And that means that the immature RBCs are now being broken down. Okay, so know that with pathological jaundice, they get it from birth. And we see that's a condition, that's a disease that the child brought it from life. And it will peak around 3 to 5 days. Okay, in 10, if there are 10 babies, okay, after 37 weeks, they are 10. Okay. If there are 10 babies, you see, and if they are having pathological jaundice, you see this jaundice continuing for first day, second day, third day, fourth day, to the fifth day. That's where we see the peak. All right, that's where we see the peak. But for preterm infants, they will continue because it has to continue because there are a lot of immature red blood cells in preterm. So that one has to prolong, okay, to what? 5 to 7 days, about 1 week. They will still have jaundice. Okay, that's where it peaks. All right, and it starts resolving. So it can resolve within 1 or 2 weeks, depending on the baby that time or preterm. The preterm always they take longer, okay, to resolve. But with 10 babies, within a week, it resolves. All right, and they feed. When we feed early, it stimulates the intestinal activity. Okay, so that the bilirubin level will go down because once you feed, it will help the conjugated one to remove. Because if it has been conjugated, it needs stool, it needs urine to get out of the body. So if you feed early, then it has now gotten its transport system. Okay, so it will leave out of the body. And another thing is that you have to prevent children because hypothermia, if the child is hypothermic, okay, that one can cause acidosis. And that would interfere with bilirubin conjugation as well as its excretion. So please take note of this. Once the child is hypothermic, that's why when the infant is born, we typically have to wrap the baby to prevent evaporation. Okay, so we want to prevent hypothermia. Okay, if the child is hypothermic, okay, that one will cause acidosis. Are you please? Okay, because that one metabolism is slowed down. Okay, and once metabolism slows down, it will lead to acidosis. So that's what we have to know. Okay, and
Sir
prevent.
Frank,
Yes, please.
acidosis in which form? Acidosis in a way that there is accumulation of bilirubin.
There is what?
There is you said there will be acidosis.
Mhm.
And I'm saying that metabolic acidosis on account of what? Is it on account of the accumulation of the bilirubin or the conjugation?
Hypothermia.
Of the
Hypothermia.
I understand you that the hypothermia, you said that the hypothermia could lead to metabolic complications, as in slow metabolism, and then it will lead to acidosis. That's what you said, right?
Yes.
And I'm saying that acidosis on account of what? Is it on account of the unconjugation of the bilirubin, or which one? Or the accumulation of the bilirubin in the system?
For the acidosis.
Yes.
I don't understand your question, but let me answer how I understand. One thing is that we are saying that we want to prevent, or if the child is having jaundice, we want to prevent it from being prolonged. Do you understand that? Do you understand that?
Yes,
Okay.
I understand that.
All right. So if the child is hypothermic, okay, that one will cause what? Acidosis. It leads to acidosis. Do you understand that? Because if the child is hypothermic, one thing is that it's going to result in a lot of increase increase in oxygen consumption. Okay. Or so the tissues will consume a lot of oxygen. And that one will eventually lead to hypoxia. Okay. And once there's tissue hypoxia, okay, that one, has acidosis result from acid production. Okay. And that if there's hypoxia, the cells are hypoxic. Okay. So that is one issue. All right. And if it happens like that, okay, that one, once acidosis has been formed, or once there's acidosis, okay, and that one is going to prevent or is going to interfere with the conjugation of the bilirubin. All right. So acidosis, know that acidosis interferes with liver conjugation. Acidosis interferes with conjugation. And once there's acidosis, and acidosis also interferes with excretion, because acidosis has effects on the kidney. Oh, you know that. All right. Acidosis, they have effects on the kidney. All right. And that one is going to prevent or interferes with its excretion. Once the kidney is having a problem, it's going to affect its excretion. Do you understand? So that is the cascade. So if we are having pathological jaundice, prevents the child from getting hypothermia. If not, you're going to worsen the condition. Excretion is going to be delayed. Conjugation is going to be delayed. And that's how the process, that's how it leads to the delay of excretion of the bilirubin from the blood, or if conjugation as well. Do you please understand what I'm saying?
Yes, I get you. Thank you.
All right. So
Boss Frank,
yes, please.
please, I'm still not getting the difference between the pathological jaundice and the physiological jaundice.
Okay. Physiological is just normal, the physiology. There's no underlying condition. It's the physiological way of removing, because with physiological, we know that obviously once the baby is born, there's going to be excess, what's the name? Red blood cells. Okay, immature ones. All right. And once there's immature red blood cells in the body, obviously the body has to work on that because it doesn't need it. The body doesn't need it. So how is the body going to work on that? It has to be broken down. And once it's broken down, the liver has to conjugate before it is removed. Okay. And that one, because there are many, the immature ones are many. And once it's being broken down, there's going to be release of what? Bilirubin. And if the bilirubin, the remover, because there are so many in the blood, it either weighs the body's ability to conjugate and to excrete, because the body can't overwork or can't work on that much, so much of the bilirubin in the blood. Do you understand? So the excess ones is going to what? Be seen as jaundice. Okay, because the body is overwhelming to the body, because the liver has to conjugate the bilirubin or the excess heme. But what the liver is doing, because of a lot of immature red blood cells, the body will break all of them down, and the liver cannot handle such much work. Do you understand? And that one will lead to the jaundice. That one, there's no underlying, there's no any condition. There's no underlying condition. It's the normal way of removing, and that is normal to everyone. Once you give birth to the baby, you're going to see some minor jaundice. If the baby is preterm, obviously you're going to see that one. Or if the patient is term babies, you will see, but sometimes minimal, because the liver is well matured to handle the excess heme. Are you pleased with it? But if there is pathological means that there's underlying pathology, there's underlying condition of which the child is bringing from birth, from the womb. Okay, and that one is pathological because the child is bringing from the womb. And that one, you are going to see it in the first 24 hours of life. Do you understand? So once the child is born, you see that the child is having jaundice, even right after birth. That is the pathological. It's the child brought it from birth. Do you understand that, please?
Yes, thank you.
Yes. So that is what is happening. Any further question? Okay. So if there's no other question, then let's finish up with this one, with the pathological jaundice. Okay. So with the this pathological jaundice, okay, know that it appears in the first 24 hours. The first, you know the onset. The onset will differentiate either it is pathological or physiological. So once the baby is bringing in from birth, bringing this jaundice from birth, know that it is a pathological. It's a condition that the child is already having. But the physiological would always be after 24 hours. Do you understand, please? And you should also know the cause. Because with the physiological, I told you that it's just a normal thing that the body undergoes. It's just a normal breakdown, okay, of that fetal red blood cells, okay. And then if there's immature liver conjugation, okay. But the pathological, it could be that the mother, we are having RH incompatibility. That's a condition that the child, because of the mixture of blood, okay, in utero, maybe from previous, maybe from what's the name? Placental abruption. Okay, maybe from amniocentesis. Okay, so a lot of, so it means that the child got it from utero, and that one is pathological. There's hemolysis because of blood incompatibility. That's a disorder. That's it's a pathological. So know the cause. So once the mother is, or there's a pathological cause, like RBC's incompatibility, okay, it becomes what's the name? It becomes a pathological jaundice. Do you understand? If we are having impaired liver conjugation, okay, for example, we are having an infection. The child got an infection from utero. Okay, we are having liver immaturity. Okay, it means that there's been an impairment in the conjugation. The liver cannot conjugate or convert the unconjugated to conjugated. And that one will lead to jaundice, and the child will bring it from birth. All right. Or if there's excretion, because I told you that the production as well as what? Excretion can lead to jaundice. So with excretion, the bilirubin cannot leave the body, whereby. And if the person is having liver disease, so liver produces the bile and it's excreted through what? Stool. So how is the liver going to handle this? They're not going to produce bile because it's diseased. And this is a pathological. You have a pathological cause. Or biliary obstruction. The bile duct, there's obstruction. That's a pathological cause. And that one leads to pathological jaundice. The child will bring it from birth. All right. So let's know the cause. Let's consider this and we close. So if we have hemolytic disease, like ABO incompatibility, you, the mother, you're having O blood, and the child is having A or B or AB blood. You know that those bloods, if they mix, it's incompatible. Okay, it's incompatible. All right, so please know that. And so we have RH incompatibility and we have ABO incompatibility. The RH incompatibility has to do with the results. If the mother is negative and the child is positive. And the ABO has to do with the blood type itself, not the results. So if the mother is O and the child is A or B or AB, they are incompatible. And that can lead to hemolytic. Hemolysis means the breaking down of the hand. And that is hemolytic disease. So hemolytic disease, we have the ABO and then we have RH incompatibility. And that is a pathology. Okay. So when you have infection, that one can also cause that. You're having infection, the child got it from utero. Okay. Or prematurity. That is not a cause. Or there's trauma, cephalohematoma, or GSPD. So these are the major causes or causes of what? What's the name? Pathological jaundice. All right. So I want to end here. God willing, tomorrow, then we continue. Any questions before we close?
Sir, please, a question.
All right.
This ABO incompatibility, like, I'm really wondering what could lead to it. Is it during labor, or how does it mix? How do the mother and the child's blood mix? Like, I want to just understand the circumstances.
So know that during delivery, you can have AV incompatibility. So far as there's going to be blood. Okay, so during delivery, we can have a mixture of the mother and the fetus, that of fetus. During what I said about if there's amniocentesis as presented the last time. Okay, we are passing a needle. Okay, there can be a mixture of blood. If the mother is O and the baby is A, B, or A, B. Okay. And if there's maybe placenta previa, as we are all studying, once there's a separation, okay, know that we have the once there's separation, there's going to be bleeding. Okay, and if there's bleeding, know that the surface of the placenta to the fetus has been exposed. So the mother's blood can mix with that of the fetus. And the fetal blood can also mix with that of the mother. When there's exposure, there's a break. There can be a mixture. So it can be during delivery. Okay, during delivery, if the mother gets if fetus gets trauma during delivery, and then mixture of maternal blood, because once there's delivery, there's going to be obviously blood. And if the child gets trauma, there can be mixture of blood.
Okay, sir.
You understand, please?
Yes, sir. Thank you.
All right. So with this pathological and then physiological, just know the when it is certain of like the onset. Just know the onset. When does pathological jaundice see, and when it that of physiological see? One is within that 24 hours. That means the child brought it from utero. That is pathological. And after 24 hours, it's normal physiology. That's normal. You know what is causing that. Is it a normal process or underlying condition? That is pathological in the underlying condition. Okay. Know when it is peaking. Know when it peaks. Okay. So if we are having what's the name? Physiological jaundice, because we said that in preterm they peak around day 3, day 4, day 5, but in post-term, in 10 babies around day 5 to day 7 in a week. All right, and it resolves, but it resolves earlier in term than in preterm. Okay, so that's what we have to do. But with pathological, because the child is bringing from utero, it rises so quick. All right, so know that, and know when it resolves. Know the resolution or the duration of how it goes away. Know that because it's a physiological, okay, because it's physiological. Do you think it will take a longer time or a shorter time to go? Physiological. What do you think? Will it take a longer or a shorter time?
A shorter time.
A shorter time.
Yes, because it's physiological. But once we have underlying condition, there's a condition ongoing. So it will take a long time, okay, until the condition goes. But physiological, because it's a normal thing, that's physiology, normal physiology. It takes a very short time. Within a week, then it goes. Okay, maybe 1 week, 2 weeks, then it goes. But if it's taking longer time to go, that is obviously pathological. All right, and know how it rises. Okay, know how it rises. If it's like physiological, that one, because it takes about 24 hours before you start seeing, it will rise slowly, because that's the normal way of breaking down. So slow rise. But with pathological, because there's underlying condition. Because with underlying condition, if you have RH incompatibility, that one there's quick or ongoing or frequent destruction. And that one, it will rise so quick. All right. But physiological slowly. But when there's condition, RH incompatibility, and that is breaking down just like that. So it's going to elevate the bilirubin so quick in pathological. All right. So know what is going on. Okay. So, and another thing is know how it's treated. Okay. Once if it's physiological, you give your breast milk, you hydrate or you do phototherapy, and then it goes away because it just needs what? Something a way out. Just needs the blood. Sorry, the stools to remove. It just needs the urine to remove. Okay. So know that. But if it's about pathological, its intervention will be extensive. Okay. You need phototherapy. You need, if there's ongoing breakdown, you need something to stop the ongoing breakdown. That's IVIG. Okay, IVIG. IV immunoglobulin to stop the hemolysis. Or sometimes if the breakdown is so extensive, especially with RH incompatibility, you have to do exchange transfusion. You have to remove all the blood in the infants and replace it. That's exchange transfusion when it becomes so severe. So that is what you should know. Thank you.
Hello, Boss Frank.
Yes, please.
Please, I have a
All right. So we are going to start with we ended with this. So we are going to start with the assessment. As you all know, when there's jaundice, obviously we are going to see that yellow discoloration of the skin. All right. And the sclera as well. The patient can feed. It affects the child's feeding. And one thing that you should know is that with all children's condition, most of them, okay, they have poor feeding. Most of them, almost 90% of the children's health condition experience poor feeding. Okay. And jaundice, if we have jaundice, we know results from bilirubin, hyperbilirubinemia. So obviously the bilirubin level is very high. They should be lethargic. Okay. As well as, because this one, there's ongoing destruction of the red blood cells. So you know the red blood cells, that's one carries what? What does it carry?
Oxygen?
Yes, very good. So patient with lethargic and progressive signs of what? High-pitched cry, hypotonia, as well as post-suck reflex. Okay. When it reaches this stage, then we are getting the bilirubin into the brain. Yesterday, I told you that when we have high levels of bilirubin, for them, they are only eliminated through the kidneys, that urine, and the stools. Okay. And becomes poisonous or toxic to the body if it's not eliminated. But it can just cross the blood-brain barrier and affect the brain. Right. So we are going to see jaundice in the mucous membrane, on the skin and the sclera as well. All right. So always assess, when you want to assess the child's skin, do it under light. Do it under natural light. That one will give you the clear view of a child's skin. And one thing that you have to do, this one is when you're assessing the child's skin. Okay. You press a finger over the bony prominence, right? Or the tip of the nose. Okay. To press out of the capillary blood from the tissue. That's how we assess. All right. Either a bony prominence or on the nose. Okay. Once you press and you leave it, you see that yellow color there. That's how we do assess. And one thing that we also know is that the spread of jaundice is cephalopodal, meaning that it spreads from the head to the toes. Okay, so it starts from the head and spreads to the chest, abdomen, arms, and the legs. Okay, so when you see it in the hands and in the palms, that tells you that that jaundice is severe. Because for it to spread from the head down to the soles and to the palms, that tells how severe the condition is becoming. Okay, and one thing is that we use transcutaneous bilirubin testing. Know if we are having jaundice. Okay, that's another way of testing for presence of jaundice. You get it, please. So, if the client is having a dark skin, or the baby is having a dark skin, okay, we have to know that in a very less pigmented area, that's where you are going to assess, and that is the mucous membrane. And we are looking at the sclera or the lips. That's the mucous membrane. Was very hard for us to determine in those who are dark. So in darker people or clients or children, we use the mucous membrane. The mucous membrane. And when I say the mucous membrane, you're looking at the sclera. Okay, we are looking at the lips, the mouth, not the skin. It becomes quite difficult to assess for those who are dark. All right. And we have what we call connectors. Connectors is just when the condition gets to the brain, when the jaundice, okay, the unconjugated. Over here, we are looking at the unconjugated. When the unconjugated bilirubin get to the brain. All right, so that is what is meant by connectors, and it causes a damage. Okay, causes a damage to the brain. All right, so that's what you should also know. Once the patient or once the unconjugated bilirubin gets into the brain, it's going to cause that damage to the brain. Okay. It's preventable. We can prevent it. Okay, but know that when it gets to the brain and starts having effects on the brain, it is a permanent thing. Please note, it's a permanent damage. Okay, connectors is a permanent brain damage. Okay, as a result of what? The unconjugated bilirubin, because it's not getting a place to live. So the only place is to cross the barrier and get to the brain. Okay, so when it happens like that, it's going to result in the following signs. When the patient is getting epistasis, okay, that's active or seizures or coma. When it reaches this, know that the patient is having connectors. Now, this one is severe. It's a complication of hyperbilirubinemia. Do you understand, please? Do you understand? Okay. So this one, of course, neurotoxicity. Okay, the unconjugated bilirubin, which is not having a place to live, will cause neurotoxicity when it gets to the brain. Okay, that is what you have to know. And all has to do with the unconjugated, because once it's conjugated, it is surely lead. But if it's not conjugated, then it gets to the brain. Okay, so that's how it happens. Okay, so let's suppose that the child is what's the name? It's prematurity. Okay, so for you to get connectors, we have some of I would say, risk factors that will lead to this. Because for the patient to get connectors, it means that we are having unconjugated bilirubin in the blood, which is transported to the brain. And that's if the child is premature, we have a lot of immature red blood cells, which will lead to the breaking down, hemolysis, and eventually becoming unconjugated because the liver cannot handle that. The liver is immature to handle that. So when you are premature, it becomes a risk factor. All right. When you are premature, it becomes a risk factor. So that's what you have to know because the liver is immature. Okay. And another thing is that, so all the things that will cause breakdown of red blood cells. So yesterday we talked about GCSPD. Okay. Where the body, because the body cannot defend itself. And when there is free radicals, those poisonous things in the blood, they start attacking the red blood cells and cause destruction to the red blood cells. That is GCSPD. And if the child is having GCSPD, it can lead to this. Okay. So all the things that we talked about, like the RH incompatibility, the ABO incompatibility, they all can cause what? They can lead to hemolysis because that's the cause of hemolysis. So we have ABO incompatibility, can lead to hemolysis. We have RH incompatibility, it can lead to hemolysis. We have GCSPD, and that leads to hemolysis. Once there's hemolysis, that will result to what? The hem, the bilirubin part coming out and becoming unconjugated and get to the brain. So all these things are some of the risk factors. And we talked also about cephalohematoma or trauma when there's bruising. Okay, all these things, or if the mother is not feeding well, late feeding, or not doing early feeding, all these can lead to what? This. Okay, and another thing is sepsis. That's one of the causes as well, because sepsis leads most of the times. That's why in sepsis, you know that sepsis can lead to DIC. Okay, sepsis is one of the causes, major causes of DIC. Right. So when the child is having sepsis, can lead to breakdown of these, the RBCs, and later they get to the brain. Okay, sepsis is one of the factors, as well as polycythemia. Okay, poly means what? Many. Cythemia, that is more cells, blood cells. Okay, so when we have more of the blood cells, okay, the only thing is for the body to breathe some. So polycythemia can also lead to jaundice, and eventually they can become unconjugated and get to the brain, causing connectors. So know that connectors is permanent damage, not a temporal. Once bilirubin unconjugated get to the brain, it is a permanent damage. Take note of that. It's a permanent damage. Okay, it's a permanent damage that you have to know. All right. So if you have a child and the child is not able to feed well, your child is having the tone, okay, when the child is like weak, cannot grasp you well, okay, you're having hypotonia. You have, the child is not able to suck well, all right, or the child's activity is reduced, or when you're having seizures, or maybe lethargy or coma, that tells you that the unconjugated bilirubin has now gotten to the brain. I understand. Do you understand this? And once we are having all these things, they can lead to a lot of let's say the child having that high pitched cry, the high pitched cry. All right, and the opistotonos that we talked about. Okay, to know that when you get to the brain, that's what you have to do. Initially, the child will have that weakness. Okay. Then later, that is the hypotonia. And later they will have hypertonia. Okay, when the seizures start coming in, but we know that seizures have to do with them, the muscles become so rigid and stuff. So in late sign of connectors, they have that hypertonia. Okay, and this will affect their breathing as well. Sometimes they have apnea. Okay, so that is what you have to do. But once it gets to the brain and causing permanent brain damage, know that these things will lead to a whole lot of conditions like cerebral palsy. Okay, cerebral palsy can result from connectors, can result from the unconjugated breathing crossing the barrier to the brain. Okay, it can also lead to hearing loss. Okay, can affect your hearing. When you have unconjugated breathing, can affect your hearing. Okay, as well as leading to seizures, seizure disorders, as we are talking about. So that's what we have to. All right. Okay. So, how do we intervene? We are saying that it is only removed through urine, so we have to keep the child well hydrated. Okay, keep the child well hydrated so that the one that has been conjugated, okay, can be removed. All right, and early frequent feeding. Early, we start feeding as early as possible. Okay, so that it will hasten the passage of meconium and encourage excretion of bilirubin. So early feeding is important. Okay, so when you get the question on that end, you have to choose early feeding as part of the thing that's or the anticipated interventions. That is one, early feeding, because it's through removal, through the through stools. Okay, and one thing is that always try to know the amount of feedings that the child is having, wet parts, the number of it, and stools. It's true that you know. Okay, if the child is feeding well, yes, know that it's going to affect the excretion. Okay, so know the number of what feedings. Okay, wet part. Okay, because it passes through urine, so that one will help you. All right, and also stools as well. And you have to report if the child is having jaundice in the first 24 hours of life, and that is what type of jaundice? First 24 hours of life. What type of jaundice?
Pathological.
Pathological.
Pathological. But the child brought it from what? Birth. The first 24 hours. Pathological. And if you have any other abnormal signs like the acting, okay, the child acts, that is opisthotomus. I hope you know that position. Have you seen that position before? Opisthotomus position. Have we? Okay, let me show you how it looks like. So if you know that your child is having these things. I hope you can see it. Okay. See this. All right, that is opisthotomus position. That is a sign of what? Connectors. Okay, that's permanent brain damage. All right, connectors. It could be a sign of tetanus, meningitis as well. Okay, so all these things are what we call connectors. That means you're having a damage in the brain. Okay. So that is opisthotomus position that we are talking about. All right. So, we also have to prepare for phototherapy. And we have what we call Billy light and Billy blanket. With the Billy light, we are looking at the normal one that the child is placed under. Okay, under. And then there's lights over it, over the baby. But the blanket, it has a light, okay, that is placed around the baby. And this one doesn't cover the eyes. Okay, it's only the Billy light that covers the child is placed under. And then there's like in an enclosed area, and the lights be on. But the belly blanket, the child can be on the laps of the mother, while the child is in the blanket. Okay. And this one is not going to cover the eyes. So with this, we are not going to. There's no need for eye patch. All right. There's no need for eye patch. Okay. And the infant can be held at the hand on the hand of the mother. Okay. That's the belly blanket. But the belly light is not like that. Okay. And I told you yesterday that the patient will need IVIG. Okay. And that is for hemolytic disease. We want to reduce the antibody-mediated RBC's destruction. There's a lot of antibodies which have been formed, and that is causing the destruction of the RBCs. Okay, when the mother develops that hemolytic disease. Okay, so when we have hemolytic disease, like we have RH incompatibility, or we have ABO incompatibility, there's going to be an antibody, which this antibody is now going to fight the RBCs and cause destructions to the RBCs. That is hemolysis, destruction, okay, of the RBCs. And once it becomes like that, how are you going to stop the destruction? And we're going to stop it by giving an intravenous immunoglobulin. Are you please okay? So that is what we have to know. We give intravenous what? Immunoglobulin. That's IVIG. And the purpose is to reduce the destruction. Okay, we are going to reduce the destruction. All right. So we are going to reduce that harmful the immune response, because there's been an immune mediation. And we are going to reduce that harmful immune response. Okay, in autoimmune conditions. All right. And another thing is that when we have a patient like this, when you give the IVIG, we are also replacing the immunity. Okay, it's for immune replacement. Okay, it's for immune replacement. So that's what all that is going to do. So if we have antibodies ongoing, you're just going to like neutralize the antibodies. Okay, it's going to neutralize the antibodies. That's what it's going to do in the body. Okay, it's going to neutralize the antibodies there. If the ongoing destruction or inflammation, that one is going to reduce. Okay, so in this case, it also provides us a passive immunity. Okay, it's going to provide a passive immunity to the baby. I place okay. You understand? So that is all that we know. So it means that when the mother, a person.
Yes, please.
Okay.
Please, with the bill light or the bill blanket, is it the same thing?
No. I said the billy light is the normal phototherapy that we know. That one, the child will be under the phototherapy and is covered, and the light will be on, the child will be exposed with the exception of the eyes and the gonads. Okay. That is the billy light. But the blanket is the normal blanket, but it has light. That's a billy blanket. Let me show you how. It's not the same. Okay. Okay. Have you seen it?
Yes, please.
Yes, that's the billy. blanket.
So this is the bill blanket.
Yes.
Okay.
All right. That's a blanket. All right. See, the mother can hold the baby.
Yeah.
That's the blanket that we are talking about. Right. Oh,
Okay. Thank you.
but the Billy light show you like this. You can see it, right? Can you see it?
Yes, please. I can see it.
Yes. So this is the Billy light.
Okay.
So this one, the child is placed under inside it. Okay. And covered with the light. But they regulate the light. Okay. They set the light up. Okay. And the eyes are covered as well as the gonades. Okay. Then we put some diaper on. Okay, just to cover these areas are covered. Only these areas, 2 areas, the gonads and the eyes. The rest are exposed. That's what you should know.
Okay.
All right, so we are going to be immune globulin. Okay. So with immune globulin, we give it when patient is having the hemolytic disease, okay, like ABO or RS incompatibility, or even in Kawasaki. I hope in Kawasaki we give, right? We learned Kawasaki recently with Bolgia. So we give IVIG, okay, in Kawasaki, all right, together with aspirin. I hope it's in aspirin. With aspirin, we give it in Kawasaki, okay. So that one you should also know that. So we give immune globulin in this most of the time those with immune conditions, like when we have Guillain-Barré syndrome. Okay, they give it. All right, that's what we have to know. And with this, when we are giving, it's like it's something that we have to obtain some information before we give. Okay, before we give, we have to know if the patient has already given this before, or even having any heart or kidney problems. Okay, that's what we have to know. And because of that, we do hydrate the child because of the effects of the kid. So we do hydrate the child when we are giving this one kid. But know that it can result in reaction. So because of that, you have to be monitoring if the child is developing fever, developing chills and those stuff. Okay. Or if developing back pain or something like that. Okay. So we have to. But once it happens like that, you know that it's reaction that the child is developing. So we have to stop the medication. Okay. So that is what we should do. All right. So this one can cause anaphylaxis. Okay. So you know what happens in anaphylaxis. That has effect on the blood. That's patient can develop hypertension as well as what on the respiratory system. Okay. By patient developing breathing and stuff. Okay. So that's what another thing that we should. All right, Sister Lydia. Sister Lydia there. Okay, maybe. All right. When insurance comes, then you okay. So we also have what we call exchange transfusion. Okay, exchange transfusion. Out yesterday, I told you about it. Okay. So exchange transfusion, we have to know that we are just removing what's the name?
Hi, Reverend.
Yes, please.
Please, I forgot to turn my audio on. I was asking question on the first slide, the one you just came, you said eye patches is not required for which one? On your slide.
The blanket, the blanket.
It's not required for the blankets, right?
Yes, please.
Okay, thank you.
All right. So that is what we have to do. And with exchange transfusion, look at the way. Sorry. Yeah, exchange transfusion. And with exchange transfusion, know that we use exchange transfusion when we are having a serious problem. Okay. We use it when we are having a serious problem. So when it starts, the first thing is to do phototherapy with the use of Billy light or the Billy blanket. Okay. But if you have to do what's the name? Exchange transfusion, that one means that the condition is so critical. Okay. Its condition is so critical. So we use exchange transfusion just to remove the bilirubin, especially the unconjugated one in the blood. Okay. And the ones that the antibody has attacked, the red blood cells that the antibody has attacked. Okay. We want to remove it. Okay. That's what you have to do. And that one has to do with the maternal antibodies, because it's the maternal antibodies which has formed in the baby's arm. Okay, so we are going to remove the maternal antibodies in the blood and replace the blood with another different blood that has been donated, but that one is compatible with that of the child. Okay, so and we do this all because we don't want the bilirubin to get to the brain. That's our fear. We don't want it to get to the brain. So we want to prevent encephalopathy, bilirubin encephalopathy, or what? Kinecteros. Okay. Bilirubin encephalopathy or kinecteros. So when you say bilirubin encephalopathy, it means that it's bilirubin which is causing the confusion, which is causing the seizures, is causing those signs. Okay. So bilirubin encephalopathy or kinecteros, we do exchange transfusion. Okay, to remove this one. So, and this one is not a quick removal. You do it small, gradually. Okay, it's just a gradual removal. And that they remove small amount of it. Okay. And at that same time, while they are removing, they are replacing it with what? A compatible blood. Oh, you get it. So this one is not, as I said, is not a first treatment. Before we do exchange transfusion, it means that the condition has become critical. Okay. So that is what you should know. All right. And if we are having maybe severe hyperbilirubinemia, okay, severe hyperbilirubinemia, all right, we can do exchange transfusion. Okay. Or let's assume that the child is having bilirubin encephalopathy. Okay, or acute bilirubin encephalopathy. Okay, we have to quickly do exchange transfusion. All right. So if the child is having that, means that the child will be developing that lethargy, that's a high pitched cry, that's poor feeding. And if the child is having hypertonia, it means that it's a less sign. The condition has progressed. Okay. But because initially they are going to have that hypotonia. But if they are developing hypertonia, means that the condition has progressed. Okay. Or the baby is experiencing opisthotonos, the one that I showed you, the act. Okay. Or if the child is developing seizures. Okay. This one we can do exchange transfusion. Or we're having severe hemolytic disease of the newborn. That is ABO or RH incompatibility. We can or GSSPD. Okay, these three things. You're looking at hemolytic disease, GSSPD, ABH incompatibility, RH incompatibility. Okay, or if you've used phototherapy and it's failing its purpose. The phototherapy is not working enough to reduce the bilirubin level. Then we have to go in for exchange transfusion because we don't want the bilirubin to get to the brain. Okay, so that's all that we are going to do. All right, so that is that. And before we do this, obviously we need something like consent form. Okay, consent form. Okay, we have to do it. Okay, but know that if you want to do estrogen transfusion, you have to continue with the phototherapy until we resume with what? The estrogen transfusion. Okay, that is what you have to know. Okay, and mostly they use the umbilicus. Okay, umbilicus. The umbilicus, we have a catheter that we call umbilicus venous catheter. Okay, so they use the umbilicus to get a vascular access. Okay, so that is what all that they're going to do. But before we do a estrogen transfusion, we have to find out what is the total bilirubin level now. Okay, what is the total bilirubin level now? What is the child's glucose level? How is the electrolyte like? Because once we are going to remove blood, mind you, we are removing the what's the name? The sugar. Okay, that's the sugar. All right. Obviously, yeah, there's going to be infection because you are using the umbilical cord, the vessel. Okay, obviously, once you are passing a catheter, the child will be prone to infection. Okay, so know that it's going to happen. Okay, infection is one of the major causes. Major what name? Complication of it. Okay, major complication of this estrogen transition. So once you are going to remove the blood, know that glucose will be affected because glucose is in the blood. Electrolytes, are they not in the blood? Yes, they are in the blood. They will be affected. Okay, know your the H&H, hematocrit, and then hemoglobin, because we are removing blood. So know this. Know the blood type. Do cross match to know that the one that you are given is exactly what was the name? Exactly the same to that of the child. They are compatible. So we have to know these baselines. Okay, the glucose level, the H&H level, the electrolyte level. Okay, they're all in the blood. Okay, the blood type of the baby, and we do cross matching. Okay, you know that. So once we are doing this, we need to monitor if maybe there's temperature, because that's the complication that may result. Okay, if there's signs of infection, it will tell you, temperature will tell you. Okay, you need to monitor your vitals, if there's any bleeding, those stuff. You have to know. Okay, because if the blood is not matching well, there's going to be another hemolysis. So is the patient bleeding? How is the child glucose level? How is the child heart rate like? You have to monitor all these things. Okay, so that is what we do, right? But after doing estrogen transfusion, mind you, we resume. Yes, please.
Please, I've seen that you monitor vital signs, including calcium levels. May I know the reason why, or is to also, is it because of the superstomach that we are monitoring calcium levels?
Okay. I know calcium is also part of the what name? Electrolytes. Okay.
Yes.
Yeah, you know that. And if you are giving blood, you know that the blood they have additive. Okay. It's not like once we donate your blood, they just keep it without adding anything. They want to prevent clotting. You understand? They want to prevent clotting. So how do they prevent clotting? They use the add calcium component to it. Do you understand, please? So that
yes, I do understand.
yes, and that calcium, if they are giving it to if it's in the blood and they are giving it to patients, that one is going to have effect, and that will lead to the hypocalcemia, because this component or this calcium that acetate that they've add to the blood, okay, that one is going to bind with the calcium in the blood and leads to what? Low calcium level. That's why whenever you are giving, even those with who have been receiving a lot of blood transfusion, okay, if patient has been receiving a lot of blood transfusion, one of the best electrolyte to monitor is your calcium. Do you understand? One of the best electrolyte to monitor is calcium. If your patient has been receiving a lot of blood, everyday transfusion, monitor what's the name? Calcium, because the citrate that I talked about, that contains they store the blood with it. Okay. So it's act like as an anticoagulant, and that one prevents clotting, because your blood can be stored in a fridge for a long time without clotting. You have to prevent clotting by giving calcium, by giving the citrate. Okay, and this citrate binds with calcium. So if you give it to a patient, this citrate will bind with the calcium and reduce the calcium level of the blood. That's why it's important to monitor electrolytes. Are you okay, please?
Okay, thank you.
Okay. All right. So know that with this extreme transfusion, I told you, you monitor your electrolytes, because it's the same blood that has the electrolyte. So you monitor electrolyte. So know that with this, we are purposely removing what? The unconjugated. That is so toxic to the brain. We are removing the unconjugated. All right. And we don't stop phototherapy. Okay, we don't stop phototherapy. We keep on doing phototherapy. So once we are removing, we do phototherapy in addition. Okay, so that is what you should know. So if you are done with estrogen transfusion, how are you going to know that it is working? Because with this, you are going to see that the bilirubin level will what? Reduce. Okay, so know that once you do estrogen transfusion and know, okay, it's working. Fine, how? Because your bilirubin, initially before that, that's why we did baseline checks. Okay, by checking your bilirubin level. So if you do your bilirubin checks and you know that it is reducing, that means you are doing a good job. Your estrogen transfusion is working. Okay, maybe the child is not having anemia, because in hemolysis, it's destroying the red blood cells. So patient will develop anemia in hemolysis. Okay, so if your child is having hemolytic disease like ABO incompatibility, RH incompatibility, G6PD, the child will be at prone of what? Getting anemia. Okay, because of the hemolysis of the RBCs. So if your anemia is now improving, okay, the child is the H and H is improving. I mean that it's working. Okay, and the child is not developing any signs of connectors, fine. Okay, or maybe neurologically, the signs that you are seeing is improving. That's different. Okay, so these are the things that we have to know. But one of the complications, as we are talking about, is the infection. Okay, infection. So that's why even in estrogen transfusion, you have to monitor all these things. Know the respiratory status, because it can lead to respiratory distress. Okay, so know all these things. How is it going to affect the blood? Is there going to be bleeding? Because if the blood is incompatible, there could be bleeding, there could be thrombocytopenia and those stuff coming in. Okay, if bleeding also results, there could be hypotension, cardiac involvement coming in. All right, and your number one electrolyte is what? The hypocalcemia. Okay, because of what? The citrate that they use to store the blood, which bind with calcium. Okay, that is going to happen. And the child can even get either hypoglycemia, because we're removing this, or sometimes hyperglycemia, but hypoglycemia is common. Sometimes hyperkalemia, all these things can be resolved. Okay, so when you are doing exchange transfusion, you have to monitor your calcium level. That one, you have to do that. Know your calcium level, know your what for infection, know electrolyte, monitor for hypoglycemia. So that's it. Okay. And how do we diagnose? No, we said we are going to monitor this total serum bilirubin and measure it. So if you are getting less than 12, okay, that's okay. But more than 12 is not good. Okay. And because you know that the red blood cells, they get destroyed. Okay, they get destroyed in the body every now and then. So obviously we're going to have some levels of bilirubin in the blood. But if it exceeds that one becomes a problem. And we can do transcutaneous bilirubin measurement. Okay. And also do so because bilirubin they form in the skin. Okay, you can do transcutaneous measurement. Okay. They can do the blood type, the RH type. Okay, they can do all these things to see if there's any hemolysis ongoing. Okay, that is ABO and RH incompatibility. They can also do what we call direct home test. Okay, and this we are going because all these things have to do with what? There's been an antibody which has gone into the baby's blood, attacking the RBCs. So how do you know that there is an antibody there? That's what we do as what? Direct home test. And we have direct and indirect. Okay, direct home test. We are just detecting if there's any antibodies which have been attached to the neonatal red blood cells, and that is positive home test if hemolytic jaundice is seen. Okay, for indirect, we are just sometimes they do it with the mother. Okay, so that's what another thing that they can also do. So know your hemoglobin, your hematocrit, because once there's hemolysis, these labs values are going to be reduced. Okay. Know your reticulocyte. This is immature RBCs because when there's ongoing destruction, what happens? The body has to replace that. Okay, the body can't just see ongoing destruction. It has to quickly go through the manufacturing process to manufacture red blood cells. And one thing is that the body will not wait for the matured RBCs, okay, to fully mature before they start working. No. Okay, so reticulocyte is just an immature RBC before they become matured RBC. Okay, so reticulocyte will be a lot because there's ongoing destruction, and the body has to replace it quickly by multiplying the number of red blood cells that you have, and that one they will not wait till they become mature. So we are going to have reticulocyte count to be so high in what? Hemolysis. Okay, so when you do labs and we are having a lot of reticulocyte, know that reticulocyte is red blood cell, red reticulocyte, and that is immature form, the RBCs, and it indicates that there's ongoing hemolysis. Okay, so that's what you should know. And the complications, as I talked about, is what? Connectors. That's premature brain damage caused by deposition of what? Unconjugated bilirubin in the brain. Okay. So when you see lethargy, poor feeding, hypotonia, weak suck reflex, the child is not sucking, poor feeding, high pitched cry. The patient is the child is irritable. Nothing will suit the child. When you even take the child will be crying. When you put the child at your back, the child will be crying. You give child food, the child will be crying. The child is now irritable. Doesn't want to be pampered, doesn't want to be held. Okay. So muscle rigidity. And that one is leading to seizures. That's hypertonia, means we are leading to what? The left side. Opisthotonus, fever, seizures. They're all signs of what? Connectors. And once you see that, it is what? A complication of what? Connectors. Okay. And cerebral palsy, hearing loss. I told you that hearing loss, cerebral palsy is one of the complications when the bilirubin level is so high getting to the brain. Okay. So we teach the caregiver to report worsening jaundice if you see signs of bilirubin encephalopathy. Okay, such as what? Like, because bilirubin encephalopathy is just the beginning of what? Connectors. It's just leading to, it's a sign that you are getting connectors. Okay. So bilirubin encephalopathy, you get lethargy, you have feeding, poor feeding, you have hypotonia. But when the seizures comes in, the opposition position comes in, that is the connectors. Okay. So that is the long-term complication. You have cerebral palsy to be one of the major complications from high bilirubin level, as well as what? Hearing loss. All right. So, hemolytic. Okay. Hemolytic disease of the newborn. All right. And that is, but before that, any question on that? Any question on bilirubin? Any question? Okay. If there's no question, then we don't go for that. But let me ask you, if all these things, bilirubin level, ongoing destruction, will it affect the oxygen saturation? Is it going to affect it? Yes.
Yes, it does affect the oxygen saturation because the jaundice is affecting the anemia, the hemoglobin. So for as long as hemoglobin is affected, it also will affect the saturation for oxygenation.
Okay.
Thank you.
All right. Right. That's good. Obviously, going to happen. As shares as able to us. All right. So, when you talk of hemolytic disease of the
Boss Frank,
yes, please.
I was talking, but since my network was disturbing,
Okay.
please,
Yeah.
I want to find out during the exchange transfusion, does it mean that the blood cell, the blood of the baby, after removing it, is it that does it go concurrently while the blood is being removed from the vessels of the baby? The transfusion is also ongoing, and after the exchange transfusion, does it mean that the baby's blood becomes a waste, or it will be filtered again and given?
One thing is that I told you that with this, we are having an antibody, okay, of the mother that has gone into the child. And this antibody is attached to where? Where is it attaching? It's attaching to where? Yes, to the class. This antibody is attached to where? Where can it be found? In the blood. The RBCs. It's attaching to the RBCs of the child. So once it attaches, it gets itself attached to the RBC, it destroys it, causes destruction, breaking down. So when you are doing exchange transfusion, you are removing this antibodies which are being attached to the RBCs. Okay, so we are removing the blood slowly. That's why I told you it's done slowly. So once we are removing the blood, we are replacing it with another blood that is what compatible to that of the child. And we do it at the same time. We can't just remove the blood completely without the child having blood in the system. A lot of cells, tissues are going to die. Okay, so you remove it gradually whilst replacing that of what? The compatible one. And mostly because of the RBCs, antibodies attaching to the RBCs, we are just removing all of them. All of them. Do you understand, please?
Yes, sir.
Okay. So that's what is happening in exchange transfusion. Any further question? Okay. If there's no question, then you move on, right? Okay. With hemolytic disease of the newborn. So when we don't see hemolytic disease, and as we all know, hemolytic means that there's hemolysis, lysis in destruction. So when we don't see this and you see erythroblastoma fetalis, erythro means what? The erythrocytes, we mean what? The red blood cells. So erythroblastosis fetalis is the same thing as what? Hemolytic disease of the newborn. I hope that one's clear. All right. And once there's hemolysis, one cause that we all shouldn't forget is your anemia. Anemia, because it's the RBCs which contain the oxygen, which carry the oxygen is being destroyed. So anemia can protect this when we are doing hemolysis. Okay, when there's hemolysis ongoing, anemia, you can't forget that. Okay. All right. There are a lot of complications, and you're going to deal with them. Okay. All right. When we have, I told you we have types, different types. And one of the types is what? One of the types is what? Hemolysis, hemolytic disease of the immune. One of the types is what? I'm mentioning now and then. Is what? RH incompatibility and ABO. They all cause destruction to the red blood cells. That's hemolysis. So, and the severest one is the RH. ABO, you know, women, we've given birth to a lot of babies, of which, especially if they are O positive, O blood, okay, and their babies, they obviously there's not going to be, they are not going to be all O that time, okay. We are going to have different types, okay, and but that one is the minor form of hemolysis, but the most severe form is the RH incompatibility. All right. So that's what we are going to talk about. Okay. And as I said, it's the same as all hemolytic disease of the newborn. Okay. All right. So I think I'll do something. I'll talk about this later. Okay. I can see some drawings. Okay. I'll talk about this. So we have the causes and RH incompatibility. That's isoimmunization. That's the most severe form of this condition. Okay. And it occurs when the mother is RH what? Negative and the fetus is positive. So once the mother is negative, so whenever that's why they do it routinely. When they are pregnant, when they are pregnant, they go to A and C, they do it routinely. You have to know your RH type. Okay. So once you are negative, then you have to prepare. Okay, you have to prepare yourself. Because obviously there could be a mix of blood. Okay. All right. So the mother is always negative. And the child
Sir,
is positive.
please,
Yes.
sorry. What if the mother is positive and the fetus is negative?
You don't have problem.
Oh, okay. Thank you, sir.
You don't have problem. The last time I told you that the one that causes destruction is always the one with a gun, the one with something. So negative means that we don't have anything. Positive coming in is coming with a gun. So these are the ones that will cause destruction. Okay. So those positive which are coming. If you are living in your house, you don't have anything with you, you don't have any gun. you are safe. But when an armed robber is coming to you, he's armed and he carries something, and that is positive. He carries gun. Okay, they carry gun, and that is positive. And when they are coming, that will cause the problem. Not you who have nothing with you. All right. So when the mother is positive, means that you are armed, you are fully armed, so nothing can harm you. All right. But when you have nothing with you, negative, and someone coming to you and it's positive, that is one is going to cause a harm. Are you clear? Yes, Adin, you have a question.
Yes, please. Please help me understand. I know what we are doing is in reference to the newborn, right?
Sure.
Okay, so if the newborn is positive and per the ABO and resource compatibility, per what I know that if the person is positive, the person can receive a negative blood or a negative resource factor blood, and there wouldn't be any reaction. So if the child is positive and the mother is negative, I was thinking the reaction will be in the mother rather. But if the fetus is positive and the mother is negative, and there's going to be hemolytic disease of the newborn, I want to understand how a negative mother's blood mixing with a positive positive fetus's
All
blood
right.
is going
I
to cause a
understand you.
hemolytic.
Okay. The whole thing is that when the mother is negative, not armed, and the fetus is positive, armed. Once there's a mixture, because know that who is going to cause the harm? Is it positive or negative?
The positive.
The positive. So
Yes,
once the
please.
positive gets into maternal blood, please mute up or don't let me see the one who is that? Who is that? Please mute up or don't let me see you. I'll remove you, please. Okay. So once the positive is going to cause the harm. So if the positive gets into maternal circulation, they are now going to cause harm. Now, an antibody is going to form in the maternal blood. Okay, an antibody is going to form in the maternal blood. So, sometimes the firstborn is safe because the mesh of blood happens during most of the time during delivery. Okay, so during delivery, there's going to be a mixture of blood. And then the child's blood, which has the weapon, goes into the mother and form a weapon because it's going to cause destruction there. So it forms a weapon there. That is the antibody. In subsequent pregnancy, this antibody which has formed is now going to cause destruction to the newborn, the one that is coming. You now understand?
Okay, I do.
That's how it happens.
So it means the first child is almost always safe, but the
Yes.
subsequent ones that will be coming will be the ones to have the HDN, right?
Yes. But it's
Please,
safe if there's no a mixture of blood during the pregnancy. But if it occurs during the pregnancy, like when you are doing amniocentesis, when you are doing other procedures that will cause a mixture of blood, that's when you have to be given this because it's going to form an antibody against the blood and that against that of the child will cause destruction.
please come again.
What I'm saying is that if the mixture of blood occurs at delivery, okay, that one, the weapon is going to form during the delivery, okay, and the subsequent pregnancy is going to attack.
Okay.
But if the weapon is formed in the course of pregnancy, like you doing amniocentesis, the weapon is formed there. It's going to cause destruction to that baby who is coming. That firstborn. You understand?
Yes, please, I do. So, please, my last question, does it mean that in the event where you give the ROGAM, it's supposed to prevent these things. Or once there is that
Yes, ROGAM is going to prevent the destruction. Although the
for the
antibodies is
subsequent
formed,
babies,
yes,
right?
yes.
Okay.
The ROGAM is going to prevent the destruction. The antibody has been formed, but the ROGAM will prevent the destruction, the subsequent pregnancies.
Okay, thank you very much.
All right. So we are on the mother will produce the Rh antibodies. That will cross the placenta and destroy the fetal red blood cells. So once there's a mix of blood, maternal antibodies, Rh antibodies, are going to form. And when they form, you cross the placenta and going to destroy the fetal red blood cells. And that's one because once it's causing destruction of the red blood cells, that is hemolysis. That through blastocyst fetalis. Okay. And if the fetal blood enters the maternal positive one, enters the maternal circulation during delivery or miscarriage, okay, or any invasive procedure like amniocentesis, the mother becomes sensitized. That's the word. Okay. If there's a mixture of blood during delivery or even miscarriage or abortion or any invasive procedures like what amniocentesis, the mother becomes sensitized and produces the what IgG antibodies. Okay, and these antibodies will cross the placenta in future pregnancies and cause destruction. That's the whole thing. Okay, so during the first one, the mother becomes sensitized and cause destruction. And you have the ABO incompatibility, and that's the milder form. The most severe form is the RH. Okay, and the ABO is the minor form. Okay, and that one occurs when the mother is blood type O, and the baby is either any of them, AB or AB. Okay, and the mother forms of antibodies against the A or B or AB RBC antigens. Are you please okay? Are you okay? Can we move on?
Yes, please.
Okay. So that is what is happening here. Okay. So all this is
So
happening.
Please, sir, it means with the ABO incompatibility, it's only have an issue if the mother is type O.
Sure.
So if she's any of the blood type apart from type O,
no,
there
there's
is
no
no
with that.
issue.
No with that.
Okay, thank you very much.
Know that all the blood types, which one has no antigen? Which one has no antigen?
The O.
O. Okay.
O,
We name
the O
them.
is
Yes.
the O negative.
No, it's O. O negative is just the rhesus factor, but we are looking at another antigen, or the antigen that are the normal that has no antigen, either A or B. So if there can be blood type that has antigen A, okay, so if your blood is having antigen A, that's how come we name you as what your blood type is A. And if your antigen is B, we name you as B. And if your is having the two, okay, A. And if it is not having any of the normal antigen, then we call it what? O. You understand? I hope we understand that. All right.
Sir, please, can you repeat it for me?
All right. What I'm saying is that if your blood type. Okay, you check your blood antigen, the antigen of your blood, and your blood, you are having antigen A. That's why we say your blood group is A, because we've seen that antigen A attached to your RBC. Okay, so that's why we say your antigen, your blood type is A, because upon examination, we saw that your RBC is having an antigen called A attached to your RBC, attached to your blood, RBC. And if you check and we are having B, we are saying that your blood type is what? B, because we saw that antigen. Yes. And if it's AB, both, you're having both, you're saying AB. But if you have none of A or B or AB, we say your blood type is O, meaning that we don't have that type of antigen on your RBCs. That's Sarah.
Thank you.
Yes.
Please, with the ABO incompatibility, does it mean that mothers who are O, who have the blood group O, are always at risk of getting the ABO incompatibility when their partners are either AB or AB? Or there are times that nothing happens?
All right. So over here, we are not looking at the partners. We are rather referring to the babies, because with the destruction is between the mother and the baby. Destruction occurs between the mother and the baby. So we are only looking at the maternal blood type and the fetal blood type. Okay. So once we determine the maternal blood type, that's the first thing we do. So if we determine the maternal blood type and says, look at the type and say it's O, that's where the problem is coming. Once you are O, okay, that means you don't have an antigen A, you don't have that antigen B attached to your red blood cell. So once we see that, it becomes a problem if your baby coming is either A, B, or A. You understand?
Yes, I think my question was not clear. Let me come again.
Okay.
So I brought the partner issue in because most of the time you have them taking that of their father's blood group. So for instance, a woman is O and then the baby in vitro is A or B. Are we always going to see the AB or incompatibility? What are the signs? Is it always 100% that once you are O and the fetus is A or B, you will see an incompatibility? That's what I'm saying. Thank you.
No. If come again, if your partner is what?
I'm saying that if you are O and the baby in vitro is A or B, are we always going to see
if you are O, ask the mother or the
if the mother is O.
Okay.
If the mother is A O positive and the baby in vitro is also A positive, are we always going to see the incompatibility, or there are times that it doesn't happen? Like I want to know if it is always 100% that once the fetus is A or B and the mother is O, you definitely see the incompatibility. And what are the signs?
Yes. One thing is that once the mother is O, we are going to see that incompatibility. Once the mother is O, unless the baby coming is also O. But if not, and the baby is A or B or AB, we are going to definitely see this incompatibility. Do you understand? Or is your question answered? That's all right.
Yes, as you answered. Yes.
So once the mother is O, no matter what, that incompatibility is going to happen. Once there's a mixture of blood. Do you understand?
Boss.
Yes, please.
Please, is it possible to have a baby with an antigen when both parents are with no antigen? Like both parents are O, and you have a baby with A or B or AB.
Like, no, come again.
I'm asking if it's possible to have a baby, a fetus with an antigen, say AB or AB, when both parents are blood type O? I'm asking this because of the first question our sister asked and refer to the partner, like if the partner is A or B, because I'm thinking that it is only when one partner is A or B or AB, that is when the fetus, will also have that same antigen,
One
may
thing is that,
inherit that
yeah,
antigen.
this one is we inherit it. Okay,
Mm.
we inherit it. So if, or sister Stephanie, you want to answer? Sister
Hello,
Stephanie.
sir. Please, yes, sir.
Okay, come in.
I also have a question. Yes, sir. But
Yours is your question.
my yes, please. My colleague's question. I didn't hear the question.
Okay, please come again so that you want to answer.
Okay, what I'm asking is that, is it possible to have a fetus like say blood type O? Sorry, blood type A or B or AB, when both parents are blood type B, blood type O?
No, please. It's not
Yeah,
possible. The
yeah.
children
So
must inherit one of the
okay,
parents' blood type.
exactly. Yeah. So that is why I think our
That
first
if
sister
it
had
happens like that means maybe I urban or papa baby.
Okofa baby, yeah. So
And I think someone is also saying no blood group is inherited. Wow.
Is that what?
Someone is saying in the chat box,
I'm
we
saying
don't
no, blood
inherit.
type is inherited. That's what
It's
I mean.
inherited, yes.
Okay.
He said no,
All
it's
right.
inherited.
Yeah, that's what I wrote.
I asked
Okay.
because when our sister asked the first question, Boss Frank said that we are not talking about partner. You understand? But I'm also with the view that if the partner you are not talking about definitely is one of the, if the mother is O and then the fetus is B or AB, that means that definitely the father is A or B that the child inherited.
There's
Is that
no
not
doubt
so?
about that too. But my
Okay.
my point is that with blood incompatibility here, we are looking at only the mother and the fetus as having the incompatibility. Okay, I'm not talking about inheritance. Okay, when you are inheriting, obviously, if the mother is if the father is having O, definitely you are going to inherit the blood type. But my point here is that if with hemolysis, we are just only looking at the baby and the mother. That's what I want to chip in or address. Okay.
Oh, okay.
We are not
Thank you.
going to the mother's side, the paternal side. We are only concentrating on the mother and the baby. That's what I wanted to let you know.
So, but please, I want to ask my question now. So I want to know. Yeah, let's say the mother form, that is in terms of blood groups. Please, does it mean that this cannot really cause something like sickle cell anemia
If
in
the
the
mother is
child?
what?
If the mother is O, and then maybe the baby is type A, B, or AB, and there is the condition, maybe the condition applies that there is a mixture of blood. So, is it possible that the ABO incompatibility could lead to sickle cell anemia?
No. Sickle cell anemia is also another type of hemoglobin that we inherit. Okay. It's a type of hemoglobin that we inherit. So if your hemoglobin type is S or other type that you inherit, that's when we are going to develop the sickle cell. Okay. And that if it causes destruction, and that is it leads to anemia. That's what we term sickle cell anemia, meaning that the sickle cell, which the hemoglobin type is like a sickle. Okay. And once it passes through the red blood and the vessel, there's ongoing destruction. Well, that's not the type. So once there's destruction, will cause anemia. So sickle cell is a type of hemoglobin that we inherit from our parents. It's not ABO incompatibility leading to sickle cell anemia.
Okay, thank you.
All right. Any questions?
But sorry, I'm still not okay because there are some couples a lot will be like most of the time, I want to be O, like especially with the female, and the male will either be an A or a B, and they'll get pregnant, and you don't see anything like the ABO incompatibility. My reason for asking that is just 100% that anytime the woman is O and the husband is either A or B, we'll see an incompatibility, and then what will be the sign? Because you not always get you the female becoming O and then a male to becoming O. It is just, I mean, it's not 100% assured. So what if you get a man who is A or B? Doesn't mean that you shouldn't marry the person because of the ABO incompatibility.
So
Don't go and divorce. What I'm saying is that know that we have minor with hemolysis, we have minor and we have severe form. And I've told you that the ABO incompatibility is even the milder form. The milder. Do you understand? Do you understand?
Yes.
It's the minor form. And another thing is that once there is mixture of blood, we cannot, there's no way we are going to, this one is not going to develop. Once there's mixture of blood, it's going to form, that's why I told you that. During, especially in the first pregnancies, they might be safe. Because by then, the antibody IgG, that's the name of the antibody, IgG. The antibody IgG has not been formed by then. But once there's a mixture of blood, the antibody IgG is going to fall, awaiting for the subsequent pregnancies. So once there's a mixture of blood, obviously there's going to be a hemorrhage. Okay, and because ABO is the milder form, you might see sometimes you give birth to a baby and see that there's the baby is jaundice and those stuff. Okay, and sometimes once we start breastfeeding, if you start breastfeeding early and there's removal of this, you're not going to see that because the bilirubin is being removed from the blood. Okay, because there's ongoing destruction. And once there's ongoing destruction, there's going to be bilirubin formation out of it. That one is being removed from the through the stools with the help of what? The feeding. Okay, and passage of what? Meconium. All right. So that's what happened. But obviously it's going to fall. But sometimes, because it's so mild, you might not need any intensive management to resolve this. Yes, Sister Stephanie.
Sir, please, I have a question. Someone asked if is it only people with O, the blood group O, that are likely to have this issue. But I thought it's people without the resource, the O negative, not specifically O.
Is O. What we are looking at is
so
not
whether positive or negative.
The resource is just a type of blood incompatibility. That's why we have resource incompatibility. When we are talking about that, we are looking at resource incompatibility.
Okay.
Okay. But we have another type that is ABO incompatibility. When you bring the positive and the negative in, we are looking at resource.
Okay. Okay. Okay.
Do you understand?
Yes, please, I get it.
But know that we have resource that has to do with the positive and the negative.
Mm-hmm.
And we have ABO incompatibility without the positive and negative. But we are looking at the mother being O and the baby being A, B, or AB.
Okay. Okay.
You understand?
Sir, please, I get it. Yes, sir.
Okay.
Thank you.
All right. I hope we can continue.
So sir, somebody was asking for the signs of an ABO incompatibility. Is it only the bilirubin aspect, or is there any way we can have, because I've had with the ABO, like what you are saying, I am O positive and the husband is C, and I think all my 4 babies they came with jaundice. So is it are we is that what is the milder form of the incompatibility we are talking about, or are there any are there other
yes.
symptoms?
So
Yeah.
this one you are going to answer yourself. Once you are, I hope you all agree with me. Once she is like you've experienced it, or you are a testimony to this, I hope you are the best person to answer yourself. Or so share with us how you said you are O what positive, right? O positive or negative? Is that
Yes, O positive, yes, please.
O positive. Okay.
Yes.
And all the children that
they
you
all
had
came with jaundice. Yes.
jaundice. Okay. So tell us, was it how was it, and how did you manage that? So that's what we are doing now.
Yes.
Because we are going to talk about the management.
When you were trying to say the milder, somebody asked if there was something. Is it compulsory that every person must check the husband's ABO before they get married? Because in Ghana we don't do it. We just So that is, I think that was where my mind was going, because I as an O positive, my husband is A, and then we have babies. And I realized that they all had jaundice. So when you were saying that it's a milder form of the incompatibility, my mind went there, that maybe they come with jaundice, but as time goes on, it will just, after treatment, they are okay. So maybe that is where the milder incompatibility is coming from. Yes. So they all had jaundice. And after a week it was treated. I had 3 in Ghana in 1 year. So they all went through the therapy, the treatment, and then they were able to resolve within a week or 2, less than 2 weeks, yes. So I think that is where the milder form is coming from. That is the ABO incompatibility.
Okay. Thank you so much. I hope it's clear now. All doubts clear, right? So it's a milder form. Okay, it's a milder form. You wouldn't go to the extent of doing exchange transfusion. Okay, so that's a milder form. So know that with ABO incompatibility, that one is a milder form. But when you are talking about the positive, the negative, that one we are looking at. So doesn't matter if you are with ABO incompatibility, doesn't matter if you are O positive or O negative. Once your blood type is O, you surely come. All right. And if when you are talking about the positive and the negative, that one we are looking at the incompatibility, the resource incompatibility. Are you please okay? I hope we are okay.
Yes, boss.
Okay. So that is what you should know. Okay. Another thing is, I want to ask you a question. Does O blood has an antigen? ABA and AB or AB antigen? Yes. It doesn't have the AB or AB antigen, right? So that is what.
Please, your question is not clear.
I was asking if blood type O has A or AB or B antigen on their surface of the red blood cells.
You said earlier that they don't have.
Okay. So they don't have that antigen type. Okay. So that's what we should. Okay. So let's continue. Yes. So we are looking at the clinical manifestation. So with this, if there is a destruction, obviously there's going to be anemia, because the same hemoglobin That's getting destroyed. Okay. Enlarged liver and spleen. Who can help us? Why are they getting enlarged liver and spleen? Yes.
The liver is overwhelmed with the high level of unconjugated bilirubin, so it has to work hard to conjugate them. So in working hard, it changes its structure by increasing in size to accommodate it.
Okay. Any addition? Yes. Anything? Mm-hmm. Anything? All right. So
Well,
what?
sir,
Yes,
please, I'm
please.
trying. So I think because there is hemolysis going on, the body to compensate hasn't will be trying to make more red blood cells. But how the liver to be working hard to remove the antibody
Okay. Okay. Thanks.
antibody the red blood cells that have been depleted.
Okay. All right. So know that in the body, which organs produces the RBCs or red blood cells? Which organ? Which organ? The bone. Hmm? The bone marrow. Okay. The bone marrow produces cells, blood cells. Okay. So if there's ongoing destruction, and the bone is not able to produce, because in that cases, I told you that when there's ongoing destruction, there should be a replacement. And that's where the reticulocytes comes in, the immature red blood cells. Okay. And one thing is that if the bone cannot handle the destruction, the ongoing destruction, because it has to produce a lot of red blood cells. A lot of red blood cells to replace it. Okay. And if it's not able to, it's so overwhelming to the bone, it's so overwhelming to the bone, then the liver will come in, the spleen will come in to produce what? The RBCs. Okay, so in so doing, that one, the destruction is so much that they have to overwork, and that's will lead to the enlargement. Okay, so when the blood is not, the bone is not able to replenish or meet the rate of destruction, then the liver and the spleen will come in to do the work. Okay, and that one will lead to the enlargement. So production of red blood cells does not only occur in the bones. The liver and the spleen sometimes produce red blood cells, and that's when there's the need. Are you please okay? So that's why we are having a hepatomegaly and then the splenomegaly here. All right. We have edema. Why do you think there's edema? Yes. Why do you think there's edema? Hello? Why is there edema?
Hello, sir.
Yes, please.
I think it is because the excretion of waste products is limited, is defeated, is decreased. So the waste products are accumulated in the body. Thank you.
Okay. So we know that the heart has to, whenever there's anemia, the heart will get a problem because the body will think that we are not getting enough, the tissues are not getting enough oxygen. And because they think that the heart is not doing its job. So the heart rate has to go up. Okay. So eventually the heart has to be working so hard to produce enough oxygen to the tissues. And eventually the patient will get heart failure from it. So anemia is not a big joke, not a small joke. Okay. The patient can get heart failure from it because the tissues, they need oxygen. And they think that it's because it's the work of the heart to pump blood so that we get oxygen. So in the course of doing that, it becomes overworked, and eventually heart failure. And one of the common effects of heart failure is what? Edema. Because the heart has failed, not able to meet tissue demand. Okay. And then there's going to be stasis of blood and lead to what? Edema. So we have edema. The same thing with hydrops. Hydrops fetalis. High means what? Hydrops means what? We are looking at water, fluid. Okay, so hydrops fetalis, we are looking at fluid accumulating in the tissues, in the lungs, in the peritoneum, around the heart. That's what we talk about hydrops fetalis. Hydrops is just fluid. So when there's fluid accumulating in the tissues of the fetus, that's why we call it hydrops fetalis. So we are seeing edema occurring. We are seeing pleural effusion. Okay, they will go into the lungs because there's a lot of fluid accumulating in the system, and they will go into the lungs. They will go into the peritoneum, and they will form around the heart. Okay, causing pericardial effusion. Obviously, there's jaundice and pallor because there's destruction of RBCs. Anemia will come, tachycardia from anemia. Okay, because the heart has to be working, and feeding. It has to be lethargic. Okay, because the tissues are not getting oxygen, lethargy. And severe cases, because of the ongoing destruction, which the liver has to work on to conjugate, and if not able to do so, bilirubin encephalopathy, that's bilirubin will get into the brain and cause connectors, okay, leading to hypercry, poor sucking, hypertonia, seizures, and epistaxis. I hope it's well understood. Do we understand that, please? All right. So how do we intervene? We give Rogam, okay, or Rodi immune globulin. So this one is going to prevent. So when the mother is having this thing, okay, you have to prevent isoimmunization. You have to prevent maternal sensitization. And that one is done by giving Rogam. Okay, so we give this to mothers who are negative, rhesus negative. And that one, we are preventing RH incompatibility. So we give Rogam to negative mothers, RH negative mothers, okay, and that one is given at 28 weeks and within 72 hours, or if there's anything that will lead to blood mixture, okay, that's miscarriage, abortion, amniocentesis, trauma, placenta previa, and those stuff, okay, and we administer IVIG, and this once, so the one is given to prevent, and when the sensitization has already occurred, we give out IVIG, and IVIG will reduce the hemolysis. This one, the antibodies has already been formed. So we want to prevent it from destroying the red blood cells. And that's when we give out IVIG. And Rogam prevents sensitization. So know the work of the two. Okay. So we have to also know the bilirubin level. What is the hemoglobin level? Okay. So how is the jaundice progressing? Okay. So we have to know all these things because I told you that jaundice progression is what? Cephalocaudal. That's from top to bottom. So once it gets, you have to assess the severity. Once it gets to the soles and the palms of the baby, know that jaundice is severe. And that one, the child is prone of getting what? Connectors or bilirubin encephalopathy. Okay, know the vitals, know the heart rate. Because if the heart rate is increasing, it means that there's ongoing hemolysis. Okay, from anemia. All right, know the feeding. Is the child able to feed well? Know the neurological status. So over here, we are looking at neurological status, and that neurological status will assess what? Neurological status will help us to assess what?
Mental.
Yes, that's the mental state. That's the neurological status. And then I'm saying it will help us to assess what?
Connecteros.
Connecteros. If there's ongoing connecteros, or if there's ongoing bilirubin encephalopathy. Okay, so that is what you should know. All right. And know any question, please?
Yes, boss. So the IV, please, can you go back? No, yes, yeah. So do we give both of them to the mother, or we give the first one to the mother and then give the second one to the IV, IG to the baby?
Okay. So program, we give it to the mother because we want to prevent. Okay, we want to prevent. And that's when we give the IV, IE to the baby if we want to prevent the hemolysis. If we want to prevent hemolysis. That is there. We want to prevent the IgG from causing destruction to the RBS.
Okay, thank you.
Okay.
Yes, please.
Okay. Any additional question? Oh, okay. So that is what we should also know. Okay. Know when we give ROGAM. The ROGAM, as I said, it contains what? It's an immune globulin. It's an immune globulin. Okay, anti-D antibodies. Okay, and that one destroys the Rh positive fetal red blood cells. Okay, that will going to enter the maternal secretion. Okay. So that is what is happening. And we give this if the mother, I told you, if the mother has not been. So let me ask you, if the mother has been sensitized, can we give this? If the mother has been sensitized, can we give this?
Yes.
Who is that? If the mother has been sensitized, can we give this?
Yes. IVIG.
I mean, ROGAM.
No.
Okay. Any other submission? Yes. Any other? Do we give? Okay. So we know the purpose. I said the purpose is to what? Prevent sensitization. Okay. Prevent sensitization. All right. So if the mother is already sensitized, it's not going to work. Okay, it's not going to work. All right. So that is what we should. So is it given to treat hemolytic disease? Is it given to treat? Yes.
No, it is given to prevent it rather.
Okay. It's given to prevent it. All right. So that's some of the things that you have to know when it's given. Know that if there's abortion, if there's miscarriage. Okay. If there is, yeah, please, I'm coming. If there is amniocentesis, we have to do if you are doing what's the name? Chronic blood sampling, there's going to be obviously blood mixture. Okay, you have to give. If there's maybe abdominal trauma, all these things you have to give. Okay.
Center
So
laboratory,
know
is it
when
fine?
to give. Okay, know when to give this medication. All right. All right. Any question?
Sir, please,
But
is placenta abruptio part?
Placental abruptio.
Yeah.
Yes. Let me ask, is there any blood mixture? Is it obvious that there's going to be blood mixture?
Yeah, I think so.
Yes. It can happen.
Blood mixture.
Okay. All right. So obviously we are going to be. All right.
Okay, sir. Thank you.
Okay. Any other?
So, Boss Frank,
Yes, please.
please, so in case the mother has been sensitized already, is there any particular treatment for that?
Particular treatment, if the mother has been sensitized, it becomes a big challenge. So over here, we only give the IVIG just to prevent the antibodies from causing destruction to the RBCs of the fetus. You understand? But we have a way of we have preventive methods or preventive management, and have if the mother has already been sensitized, yes, we have to do some management by giving IVIG. This one prevents it from the antibody, that is IgG, from causing destruction to the RBCs of the fetus. All right. Okay.
Thank you.
Okay. All right. So know the differences. Okay. Know the differences. Once the mother is consensitized, then we give the program just to prevent it from having sensitization. Okay. What we give for the mother to give to the mother to prevent the mother from developing the anti-D antibodies. Okay. So that is what we have to do. And with this one, we give when the mother is mostly having the RH incompatibility. Okay, RH incompatibility. But for the ABO, we can give the IVIG. Okay, together with the therapy and those stuff. You understand, please? Okay. So let me ask you, how is the program given? Is it IV or IM or subcuts? How is it given? Those who have been getting the tell us, how is it given?
It's IM, please.
IM, right?
Yes.
Okay. Can someone share with us when the program was given? How was it given? And then any education that they gave you, how was it? How the experience? Can someone share with us? Or they just
Okay, Boss Frank.
Mm-hmm.
I am also an RH negative. My husband is a positive.
Okay.
So after giving birth, in fact, I was not informed by my midwives throughout my antenatal. So after giving birth, that was when I was informed, based on what the midwife who delivered me informed, that I'm supposed to take it within 72 hours. So we had to go to Kumasi. I delivered at Ejus. We have to go to CAT to get it. I think it was 400 cities or so. And then within 72 hours, I had to take it. So after every childbirth, I'm supposed to take it to prevent subsequent complications if maybe I will get pregnant again. So the last child, they were saying that there is no need, that I was afraid. I didn't know what to do, so I bought it. So I added my bank.
All right. So that's a perfect thing. I hope you are all okay. Okay. So that is her experience. Thank you so much, Mr. Grace, for sharing your experience with that. So that is program. Okay, program. Know how it's going to work. If NCLEX want to test you, that's how they test you. Okay, what is it going to do? Is it going to prevent? Is it going to cure? Is it going to do what? What is it going to do? And how is it given? We all know, but with IVIG, how is it given? IVIG. Yes. IVIG, how is it given?
It's a given IM to the type of the
IM. The name goes IV, intravenous. Okay. So that's what you have to know. And when we are doing what name? I told you that we have Combs test. All right. And Combs test, I told you they have direct and what? Indirect. The direct one, we do it to who? Direct Combs test. Yes. Who receives the direct Combs test?
The fetus.
The fetus. All right. The fetus receives the direct Combs test, and it has to be with either positive or negative. And if it's positive, what does it indicate? If the Combs test is positive, direct Combs test is positive, what does it indicate? Yes, I told you. What does it indicate? You've forgotten. Direct Combs test.
But Frank, it means there's a reaction ongoing.
It means if positive, it means that there's ongoing destruction. Okay, hemolysis, ongoing. All right. And you have the indirect, isn't it? And indirect, we do it to who?
The mother.
The mother. And that one, if it's positive, means that there's been a sensitization. Okay, there's been sensitization. All right. So please know that. Okay. All right. So if we are given what name? Combs test. Sorry. When we are given program, okay, if the mother is having severe reaction to, let's say, immune globulin, don't give program because it's an immune globulin. Okay, so that's what we have to do. Okay. All right, so we are going to.
But Frank, can you repeat yourself the last statement you made?
Okay. What I'm saying is that we are going to give this medication to a woman. So if the mother is what did I say? If the mother is sensitive, okay, if the mother is allergic to this immune globulin, are you going to give or not?
You will not give.
You know. Okay, so that's what I want to leave with you. All right. Okay. Any question before you close?
Sir, please, sorry, I want to know what is it that you said and they answered do not give.
When the mother is allergic to immune globulin.